Welcome to Radiation Therapy 101, Uncovering the Mysteries of the Basement Floor. This presentation is intended to give you a basic overview of the work that is carried out in the radiation therapy departments at each of the cancer centers in the province. The learning objectives for today's presentation are to provide you a basic overview of radiation therapy treatment, to identify the roles and responsibilities of the radiation therapist within the healthcare team, and to identify a few special considerations. The topics that I will cover include what is radiation therapy, patient and treatment flow, special considerations, external beam therapy, and I'll touch briefly on brachytherapy. So what is radiation therapy? It is the treatment of disease using ionizing radiation with the goal to either cure the disease or manage symptoms that have been created by the disease. Radiation therapy can be used as the sole treatment in some cases, or it can be delivered in combination with other treatment modalities in either an adjuvant or concurrent capacity. The intent of radiation therapy is either radical or palliative. Radical treatment is intended for cell kill and cure, and it typically involves a higher overall dose and a greater number of treatment fractions. Palliative treatment is intended to manage symptoms and provide a better quality of life for the person and the time that they have left. It generally involves less overall dose and fewer treatments. It can be difficult to understand how radiation actually works because you don't actually see anything. So we'll try and explain how it works here. When any form of radiation is absorbed in tissue, it interacts with the atoms, leaving them in an ionized or excited state, which alters the energy and chemical balance within the cells. This results in biological change, including cell damage. Unfortunately, radiation is not selective, and all cells within the treatment area are affected, both normal and malignant. However, malignant cells undergo damage. Normal cells do have the ability to repair themselves. Therefore, radiation treatments are delivered over several days to allow the normal cells to repair the damage that has taken place. This slide is intended to give you just an overview of the patient and treatment flow as each patient enters the radiation therapy department. So once a referral is received at the new patient office, the patient is scheduled to see a radiation oncologist, at which time it's determined if the patient is a candidate for radiation therapy. If they are, the physician will complete out an RT request, which is a questionnaire that exists in ARIA-MO. Once that questionnaire is completed, it is received by the clinical assistants in the radiation therapy department who use the information in it to book the patient for a CT simulation, which is their first appointment typically in the RT department. Once the CT is completed, the patient leaves and their information is sent automatically into the treatment planning department, where the radiation oncologist will outline the area to be treated and any critical structures and will provide his treatment prescription. Dosimetrists, who are specialized radiation therapists, then can design a treatment plan based on the information the physician has provided them. Once the treatment plan is complete, there are many levels of quality assurance that must be carried out on the treatment plan prior to the patient starting treatment. And once the treatment plan has been reviewed and approved and all of the independent checks have been carried out, the patient is ready to start treatment. They will arrive for their treatment. We typically provide a small patient education session in order to explain what the daily routine of radiation therapy looks like. We will give them their treatment, and while they're on treatment for up to It might be a single fraction or up to many weeks. We will continue to monitor and assess how they're doing with side effects and make any necessary referrals as needed. Once the planning CT simulation has been completed, the patient's data is entered into an additional software program called ARIA-RO, which is specialized for the delivery and planning as well for the treatment of these patients. So we actually create what's called a care path. And this breaks down numerous tasks that are identified that are required to be completed by many disciplines on a timeline from the day that they receive their CT simulation up to when they are scheduled to start treatment. The color coding identifies the tasks and the status of where they are in being completed. There are some special considerations we need to keep in mind for patients that are going to be undergoing radiation therapy. To start off with, we rely heavily on the information provided in the RT request questionnaire, as it typically shares special considerations that must be thought of for the CT sim and during the planning process. If this information is not provided or collected prior to their CT sim, treatment can often be delayed and or compromised. With regards to patient preparations, which are often seen, for example, in treatment of the pelvis with bowel and bladder preps, patients who do not prepare appropriately for the CT or daily treatment are often required to reschedule. So it's important that we ensure the patients are provided the necessary education at the new patient appointment. There's a lot of supporting documentation and patient teaching material that lives on SharePoint within the nursing folders that's often reviewed and provided to the patient at their new patient appointment. So it's important to look for that information on the questionnaire before you do your teaching. Patient positioning, and specifically mobility, is also an important consideration to keep in mind for patients that are going to require radiation therapy. For example, if we are treating areas in the breast, chest, or abdomen, quite likely the patient is going to have to be positioned on their back with their arms above their head. So if you notice the patient's mobility is limited, please highlight it to the radiation oncologist so he can ensure it within the questionnaire so the staff in the CT sim have an idea of what the patient may or may not be able to do with regards to positioning, and they can plan accordingly. An increasing number of patients who will be attending for radiation therapy do have a cardiac history where they have a pacemaker or an ICD. It's important to know that radiation treatments can alter the pacing in these devices, and we have to work closely with the pacemaker clinic to ensure treatment is being delivered in a safe manner. If you are aware that the patient has a pacemaker or ICD, please remind the RO to include this on the questionnaire as well. For patients requiring treatment to their head and neck area, it's important to understand that any dental work needs to be completed prior to the start of radiation therapy and actually prior to the CT scan, because radiation treatment will impact wound healing, and we wouldn't want to be starting anyone on treatment that hasn't healed yet from any of that dental work. In addition, some of our patients have a lot of metal fillings, and we need to use what's called a dental guard to help reduce side effects as well. And these dental guards are typically manufactured by the patient's dentist, and this needs to occur prior to the CT simulation appointment, as the patients do need to wear these guards underneath of their mask for their CT scan. The last consideration to keep in mind is if and when a patient has had previous radiation therapy treatment. When treating another area, we need to ensure there isn't any overlap, so we need to access the records from the previous treatment. And sometimes this is done actually at a different center out of province, and it takes some extra time to acquire all of the necessary documentation so we can do a thorough review of what's been treated in the doses already received as part of our treatment planning process. So now moving into the external beam radiation therapy, we thought it would be helpful for you to be aware of what the names of our equipment is called in each of the departments, as you will often see these names within the scheduling system and as part of patient appointments. So in the radiation department at the Saskatchewan Cancer Centre, they currently have 3 linear accelerators named the Oasis, Mirage, and Atlantis. They do have a 4th named the Galaxy, which is easing into retirement, and they sometimes use it as a backup bunker if one of the other units is on maintenance or in need of repair due to a breakdown. They also have an orthovoltage treatment unit, which is used for superficial disease sites, and also they have their own individual CT simulator. Here in Regina, we as well have 3 treatment units: the Varian 4, the Courage, and the Journey. And the Varian 3 is actually our oldest LINAC easing into retirement that we sometimes use as a backup as well. We too have an orthovoltage unit, and we also have our own CT simulator. We'd like to give you an idea of the workload, particularly the number of patients that receive treatment in our departments each day. So we'll just get you to look at these options and have you make your best guess as to the number of patients that are treated each day. If you guessed C, you are correct. Both departments typically treat between 80 and 100 patients every day. Okay, so how is external beam radiation therapy actually produced for treatment? This slide gives you an example of what the linear accelerator looks like. So ionizing radiation can be produced in different ways. Most commonly in our radiation therapy departments, X-rays are produced electrically in the machine, and the machine is called the linear accelerator. They can produce a high energy X-ray beam that are directed to the area requiring treatment. Treatment preparation is the first step that's required before we can deliver external beam radiation treatment. And part of the planning, part of the necessary steps that need to occur is there's often immobilization devices that need to be manufactured for the individual patient prior to the CT scan. And this slide here just gives you an example of one of the immobilization devices, which is an Acoplast mask that is manufactured when requested, when we're treating areas specifically in the head and neck, and the patient will need to wear this mask every day for their daily treatment. Once any immobilization devices are manufactured, the next step in preparation is the CT simulation. And this is an example of what the CT simulator looks like. You can see it looks very similar to a diagnostic scanner as far as the machine goes. But one of the main differences you'll notice is the tabletop is flat, not concave, like you would see in the diagnostic scanners. And this allows us to position the patient in the same spot every day. And the flat surface does have special locators where we can fix any additional immobilization devices for treatment. So the CT simulation is necessary in order to plan the patient for daily treatment, and it helps us determine the dose delivered to various areas of the body as part of the planning process. As part of the CT simulation process, we do put pen marks on the patient's skin, which you can see on the left here. And at the end of the simulation, we do need to put some permanent marks using a tattoo on the patient's skin. The pen marks are going to wash away after the patient leaves for CT sim, and we do need a permanent mark in order to get the patient lined up in the same position every day for their daily treatment. So this is just an example of our CT tattoo process. So once the CT simulation is completed, The patient is free to go for now, and their data set is automatically sent into the treatment planning department, where a dosimetrist, who is a specialized radiation therapist, works very closely with the radiation oncologist to develop a treatment plan. And the goal of the treatment plan is to deliver the highest dose possible to the area identified by the physician while minimizing dose to the critical structures around that area. Once the treatment plan is final, there is numerous double checks that take place prior to the patient starting treatment. Some of them take place in dosimetry with the assistance of medical physics, and there is a final check that's carried out at the treatment unit by the radiation therapist who will be treating the patient every day. This is just an example of a graph that would be created as part of the treatment planning process, which outlines how we're trying to give 100% of the volume of the tumor volume, the dose that the radiation oncologist is prescribing, but at the same time, we're trying to give minimal amount of dose to the critical structures in and around it. An example in the head and neck area are the parotid glands, the spinal cord, and other regions in the neck. So once the patient's treatment plan is all approved and ready to go, there are many steps that are part of the delivery of the treatment that we're going to go over here now. Those steps include patient assessment and education, accurate daily positioning for treatment, imaging, adjustments made from the imaging that's carried out, and then it's ready to beam on. We do patient education on treatment number 1, just to go over with the patient what the daily routine of radiation will look like. And also we review side effects and skincare and that kind of thing. Once the patient has started treatment, there is ongoing patient assessment and education that's carried out by the team on a daily basis. And in the event there's a concern that's arising from a side effect, we are in a good position where we can make any referrals to another healthcare provider to help assist in the management of those side effects, or in some of the psychosocial issues that a patient may be experiencing. So an example of those referrals would be to social work and to the dietary consultants. So the first step of delivering external beam treatment is to actually bring the patient into the treatment bunker and get them positioned on the treatment couch. And they're positioned in the exact same way that they were positioned for their CT scan. The most important part of patient setup is that the patient needs to be instructed to lie nice and still and let us do all the work in getting them into position. And once they're in position, the therapists leave the room and they go out to the console. So prior to delivering the actual treatment, we do a verification procedure with some imaging. And the first example here is of x-rays taken for treatment of the pelvis. And in this example, we're looking at bony anatomy to ensure that we are happy with the patient's position and that it matches the patient's treatment plan. If there's a slight mismatch, which you can see on the bottom of these slides, it looks like there's a few millimeter shift that's required. We will apply those shifts and move the patient into that position before we deliver the treatment. With regards to imaging, technology has really advanced, and we also now have the capability to take CT images on the treatment units, which allow us to do a soft tissue match and assessment prior to the delivery of daily treatment. And this is another example of a treatment of the pelvis. But instead of using bones to line up the area, we're actually using the soft tissue. So we have the bladder and the prostate outlined, and the rectum as well. And we can verify the position and again apply any necessary shifts before we deliver the treatment. So once we've completed our imaging and we're happy with the patient's position, we're ready to beam on. And As you can see in the console area here, there's a lot going on. There's a lot of computers. We do work in pairs, a pilot and a co-pilot, and it is considered a distraction-free zone. So we just wanted other staff to be aware of that in the event you need to come down or communicate to a team at a console area, it's really important that we don't engage the therapists that are driving, because any distraction could perhaps cause an unusual occurrence or an error to occur while they're actually delivering treatment. So there are often other therapists situated at the console area that could help you, or worst case scenario, you might just have to leave a message and the team can get back to you when they are able to do so. Okay, so what do patients actually feel when the beam's turned on and they're receiving their treatment? So I'll just get you to look at these quick examples here and see which answer you would pick. If you pick D, you are correct. They actually don't feel anything at all. What patients mostly experience while they're laying on the CT, or pardon me, the treatment couch, is, they can hear the machine moving around them, and they can hear some of the electronics in the head of the machine moving during their treatment as well. But as far as what they actually feel themselves, it's nothing at all. We wanted to touch just briefly on what some of the most common side effects are in radiation therapy. And the one point just to remember is radiation therapy treatment is delivered locally to a site. So any side effects that a patient may experience would be localized to the area, okay? So let's just have you answer this question at the beginning here and see what your thoughts are. And what do you think is the most common side effect from radiation therapy? If you answered B, fatigue, you are correct. And as I just said previously, side effects are specific to the area being treated, and those side effects are actually due to a result of normal tissue damage. So, for example, hair will only fall out if the head is being treated and only in the area where the beams are directed. And someone who is undergoing, for example, head and neck treatment, we would expect them to have a sore throat, but perhaps not somebody that's having treatment to their pelvis or to their chest. So we wanted to take a few minutes just to talk about side effect management in the more common side effects. And the first one we're going to talk about is the skin reaction. Anyone receiving radiation therapy may develop a skin reaction within the treatment area. The severity of the reaction varies from person to person, from no noticeable change at all to blistering or breakdown of the skin. The degree of the reaction depends on various things, such as the person's skin type, or if their skincare advice is being followed. And lastly, the actual dose delivered to the skin can impact the skin reaction as well. So for example, if we're treating someone's larynx, which is actually situated close to the surface, the skin in that area is likely going to have a significant skin reaction. But if we're treating a tumor site within the patient's pelvis or abdomen, the dose is targeted deep in that area within the body, and therefore the skin will only receive a very small dose of radiation, and as that and because that's where the radiation is being delivered, the skin on the surface in the pelvis area does not get much of a reaction. All patients are given some general instructions about skincare. They are advised to wash gently and to avoid rubbing in the treatment area. And they're only advised to use approved lotions such as Glaxo Base, which can be put on the skin to help keep it moisturized during treatment to help avoid a breakdown. Any additional skin reactions that a patient may experience will be assessed by the radiation oncologist or at RT review for additional management. Fatigue is another side effect that we help manage a lot on a daily basis, because anyone receiving radiation therapy can generally feel tired and run down. This is caused by many things. Number one, by the stress related to the illness, The stress of the daily treatment and traveling to the treatment can also take its toll. And the energy being used to prepare damaged cells. So I'll just reiterate that, the radiation is not selective. It can damage both the normal and the malignant cells in the treatment area. So when normal cells are damaged, the body's natural response is to try and repair that damage, and that does cause additional fatigue on the body. To help manage fatigue, we do encourage the patient to really listen to their body, to try and eat well and rest as much as possible. And, we do have a lot of patients that want to continue to exercise or even work. And, it's okay for them to do that, but if their body's telling them that they're getting tired and run down, we do ask them to kind of take a step back and try and reduce those kind of things. For patients that are having treatment to the GI area, or they're following a bowel and bladder prep, it's quite common that those patients experience diarrhea, and a lot of them are taking the milk of magnesia. So when that diarrhea starts, the first thing we typically do is we try and taper off the amount of milk of magnesia that they're using. And then the other thing that we can do is provide them some guidelines for a low fiber diet. And in the event those changes don't work, we can also instruct them to use Imodium as needed. For those patients who are having treatment in the abdomen area where we are catching a portion of the stomach, it's not uncommon for them to have nausea and vomiting. And in these cases, we do try and be proactive, and often they're given Gravol or another antiemetic routinely 30 minutes prior to the radiation treatment. And this somehow seems to do the trick to help keep things calmed down. But this is monitored on a daily basis as well, and we can okay, last but not least is treatment of the head and neck area, which can cause difficulty eating and a dry and sore mouth. So we do ask patients to try and take smaller meals, to add sauces and gravies to help things slide down, and to avoid any foods that are irritating, like dry toast and that kind of thing. And if they do struggle with their intake during treatment, we often do see patients that have a PEG tube inserted to assist with their dietary intake. And in some cases, this is actually done prophylactically before they even start treatment. So when the patient has actually completed their course of radiation therapy, we provide them with an end of treatment summary, which is basically a discharge summary. And included on that is the total number of fractions that they received. And then we do include also some continued side effect care and management instructions, because side effects typically peak within 7 to 10 days after their last radiation treatment. So we like to tell them, for the next 2 to 3 weeks, please continue caring for yourself and the area that was treated just like you did while you were coming for daily treatment. And hopefully at the end of that 2 to 3 week period, you'll notice things feeling better, but certainly don't be surprised if in the week after that things are a little bit worse before they actually do get better, okay? And the other thing that we include on there is a bunch of contact information in the event they need to reach us or their radiation oncologist with some concerns about their treatment or some of the side effects they're still experiencing. And actually in Saskatchewan, the team on the treatment unit where the patient received treatment does follow up with the patient with a phone call just to see how things are going. And they do document that in REMO that's taken place. Okay, so the last thing that we want to talk about today is brachytherapy, which is another form of radiation treatment, which is very different actually to external beam. And brachytherapy comes from the Greek word meaning short distance, and it involves placing radioactive sources in the area where the cancer is. So the major techniques are listed here below: interstitially, intercavitary on the surface, or intraluminally. The two that we primarily see in our departments are the intercavitary, which is used for gynecological treatments, and that's typically done at the end of the radiation therapy treatments or one per week towards the end of their treatment. And interstitially is another example of what's carried out in Regina with regards to the prostate brachytherapy program. Interstitial treatment involves inserting needles or catheters that will hold the radioactive source in the tissue. Intercavitary involves inserting an applicator that will hold the radioactive sources in the body cavity. Surface delivery involves placing the source of radiation directly on the skin surface. And intraluminal involves placing a catheter that can contain radioactive sources into the esophagus, blood vessels, and bronchus. This is a picture of our high dose rate HDR remote afterloading system. In the past, brachytherapy involved the manual loading of the catheters and applicators by staff, and as such there was exposure to the staff during the treatment. So these new remote afterloading systems allow the unit to be attached to the patient and the applicators or catheters that are inserted inside of them. And then the staff can then leave the room and deliver the treatment from outside of the room, which has decreased significantly the dose that those staff are exposed to when delivering this form of treatment. This brings us to the end of the presentation, and it is possible that you will have questions. So if you're up in Saskatoon, you can reach Jackie at the information provided there by her email or the telephone number. And if you're in Regina, you can get a hold of the RT clinical educator at 766-2220, and we'd be happy to provide you any assistance or answer any further questions as best that we can. Thank you and have a nice day.